Now let's start with our first section of infections acquired in pregnancy, and in this section we will talk about some perinatal infections that can occur in pregnancy. So the topics covered in this section will be rubella infection, syphilis, and then toxoplasmosis. First, let's talk about the rubella. Rubella is caused by the virus known as the rubella virus. More than 100,000 children born with congenital rubella syndrome every year. So it's a big number. About 100,000 children are born with congenital rubella syndrome each year. And risk of congenital rubella syndrome or infection reduces with gestation. So if it occurs early in the pregnancy, usually the risks are higher as compared to late in pregnancy. So the risks are reduced with gestational period. Here, if you see in this diagram, a woman infected with rubella during the first 3 months of pregnancy has up to 90% chance of giving rise to birth to a baby with congenital rubella syndrome, or her baby may not even survive. So as the gestation increases, the chances of developing congenital rubella syndrome decreases. So it's more serious in the beginning of pregnancy than in the later stage of pregnancy or in the third trimester of pregnancy. Clinical features are febrile rash, asymptomatic in mother in 20 to 50% of cases. So 20 to 50% of the cases, mother who have rubella infection, they are asymptomatic, so they won't even maybe know that they have infection with rubella infection. The features of congenital rubella syndrome, CRS, congenital rubella syndrome, usually sensory neural deafness, congenital cataract, blindness, encephalitis, and endocrine problems. These are also the presentations: microcephaly, PDA, patent ductus arteriosus, and cataract. If you see, this is the cataract in which there is density, opaque density of the lens is cataract is present. So all these are the features of congenital rubella syndrome: microcephaly, small head, patent ductus arteriosus. So ductus arteriosus, it remains patent and it's not closed at birth. Cataracts are present also. Some endocrine problems, sensory neural deafness, blindness. So it's a serious condition and it is caused by rubella virus, and as the pregnancy progresses, the seriousness is less and less. So it's more serious if it is present in the first trimester of pregnancy. Screening and management: if you see the rash, febrile rash is present, rash associated with fever. It's a very bad rash, very, very serious, severe rash. Screening and management. Aim of screening for rubella in pregnancy is to identify susceptible women so that postpartum vaccination may protect future pregnancies against rubella infection and its consequences. So it's important, as I mentioned in the previous slide, about 20 to 50% of women who have this, they are asymptomatic. So maybe they don't even know they have infection. So screening is important. So the vaccination should be performed after delivery. That can prevent the future pregnancies from infection and its consequences. So screening is very important. Vaccination is contraindicated during pregnancy. So even if there is rubella present, mother is diagnosed, the vaccination cannot be given because it's contraindicated. They have to wait after the delivery for vaccinating the mother. If infection occurred during pregnancy, risk of congenital rubella syndrome should be assessed. If infection occurred prior to 16 weeks of gestation, we already mentioned as the gestation progresses, the seriousness is less and less. So if infection occurred prior to 16 weeks gestation, then the termination of pregnancy is recommended because congenital syndrome is common in the early stages, and to avoid that, termination of pregnancy should be done. If occur later in pregnancy, usually give appropriate information and reassure that it might be less chances. Proper assessment of the newborn should be performed, routine checkups should be done, but before 16 weeks, pregnancy should be terminated. Then the next infection I want to talk about is syphilis. Syphilis is the infection caused by Treponema pallidum. Syphilis during pregnancy can cause serious problem for the baby, like being born too soon, mean premature birth, or too small. It can also cause death for your baby before or after birth. So premature birth, baby small for size, and then the perinatal death can also occur. If your baby is born with syphilis, it can cause problems of the eye, ear, like being blind or deaf, and it can cause the problems of the teeth, bones, and joints. So all these complications can occur if the child is born of the mother with the syphilis, and if the baby is born with the syphilis, all these complications can occur. Clinical features and screening of the syphilis. Primary syphilis, usually it has painless genital ulcer 3 to 6 weeks after infection is acquired. Secondary manifestations of the syphilis occur 6 weeks to 6 months after infection, present as maculopapular rash or lesion affecting mucous membrane. So syphilis can be primary, secondary. Primary is the syphilis in which there is painless genital ulcer is present 3 to 6 weeks after infection. But after 6 weeks, now secondary manifestations develop, which are after 6 weeks to up to 6 months, and usually there is rash, which is maculopapular rash, and it affects the mucous membrane. All pregnant women, syphilis infection during pregnancy can be transmitted to the fetus and result in miscarriage, stillbirth. Severe birth defects is effectively treated with antibiotics. So syphilis can be transferred to the fetus, and if the baby is born with syphilis, it can have complications, and then it can also cause stillbirth and miscarriages and birth defects. So all these can occur with the syphilis. Management is of the syphilis, their antenatal screening is performed. If antenatal screening is non-reactive, usually we should look if the risk factors are present or not. If risk factors are negative, no risk factors are present, then you should repeat the TRUST test at 28 weeks. This TRUST stands for toluene red unheated serum test. It's the test done for the diagnosis of syphilis, and then if risk factors are negative, usually it is repeated at 28 weeks. In next case, if risk factors are present and the test was non-reactive, then we should repeat the trust at 4 weeks. So that's the major difference. If risk factors are present at 4th week, if risk factors are absent at 28th week. If antenatal screening is reactive, then we should look at the titer. If the titer is less than or equal to 4 dilutions, then we should go for documented treatment. So with documented treatment, we have adequate repeat test in 4 weeks if the treatment document is adequate. If it's not adequate, then we should give the penicillin G 2.4 units, million units stat. Stat means right away at that point if the treatment or the documented treatment is inadequate. Then if the titer is more than 4 dilutions, usually we treat with benzathine penicillin G 2.4 million units weekly and into two times. So this is the difference. One is less than 4, we follow the documented treatment. If it's more than titer 4, then we do the treat with benzathine penicillin G 2.5 2 times weekly. So this is the treatment or management of the patient with syphilis. Next condition is toxoplasmosis. The organism that caused the toxoplasmosis is Toxoplasma gondii, and this is usually caused by if humans ingest infective oocysts from the cat feces. So any food or if hands are infected with the oocyst present in cat feces and it is ingested. And then the other factor that can cause toxoplasmosis is if the human ingests raw meat containing cyst with bradyzoids. And if the raw meat containing cyst with bradyzoids, it can also cause toxoplasmosis. Then the next step in the cycle is then the sporozoites are released, which penetrate intestinal cells in the humans. And then these sporozoites are changed or transformed into tachyzoids. So tachyzoids are formed. And then asexual reproduction takes place in the cells infected with the tachyzoid, and then the cell ruptures and there is spread of these tachyzoids in the blood. Hematogenous spread occur after the rupture of the cell. If the woman is pregnant, then the tachyzoids cross placental barrier and cause infection of the fetus and cause congenital toxoplasmosis. In other case, it goes to the other tissues. The tachyzoids invades the other tissue. Then immune system respond to that invasion, and there is formation of cysts which contain bradyzoids in various organs. So the cycle is now mainly from the ingestion of oocysts from the cat feces, and then also by ingesting the raw meat containing cysts with bradyzoids, and then these goes into human intestine where they penetrate the intestinal cells, and then there tachyzoids are formed, and then there is asexual reproduction which causes the rupture of the cell. If there is pregnancy, it can cause go through the placenta, it infect the fetus and cause congenital toxoplasmosis. In other case, the rupture cell from the blood, it goes to the other tissues, and then immune system come into action, and there is immune response, and then formation of cysts containing bradyzoids in various organs, and from there the cycle keeps on repeating itself. The clinical features and effects of toxoplasmosis on pregnancy. There is initial infection is asymptomatic, no symptoms are present. Glandular fever-like illness later on. So initially it's asymptomatic, then there is glandular fever-like illness. Parasitemia, then the parasite spread to the blood, as I mentioned in the previous slide, that once the cell rupture which is infected by the parasite, there is hematogenous spread, and at this stage it's called the parasitemia, or spread of the parasite into the bloodstream. During first trimester, severe fetal damage, but only 10% infections transmitted to fetus. So severe fetal damage can occur in the first trimester, but infections are only transmitted to the fetus in 10% of the cases. During third trimester, low risk of fetal damage, 85% infections are transmitted. So if you see, in one case, in the first trimester, damage is more severe, but the transmission to the fetus is less, only about 10%. But in the late pregnancy, in the third trimester, damage to the fetus is less severe, but transmission is more, about 85%. Effects of infection on the fetus. Toxoplasmosis cause ventriculomegaly. The ventricles in the brain, they become enlarged. Megaly is enlargement. So there is ventriculomegaly. Microcephaly, the head is small. Chorioretinitis, it affects the eyes also. There is inflammation of the retina, chorioretinitis. And then also cerebral calcification is present. So effects of the toxoplasmosis on the fetus are very serious, and as I mentioned in the previous section, that in the previous slide, that in the early pregnancy, more severe damage to the fetus is present. The treatment is depending on what trimester is the pregnancy. In the first trimester, which is up to 18th weeks, the treatment is spiramycin, and the dose is 3 grams per day. So 3 grams per day, and 2 pills every 8 hours is given. The pills available are 500 milligram pills. The dose is 3 grams per day, so pills are 500 milligrams. So we give 2 pills every 8 hours, so we can have total of 3 grams per day. After 18th weeks, up to birth, the triple scheme is used. In this triple scheme, the drugs used are pyrimethamine, and then we can use sulfadiazine and folinic acid. So these are the 3 drugs used. That's why it's called triple scheme, or triple regime is the other term used, in which we have 3 medicines. Pyrimethamine, the attack dose for pyrimethamine, or the beginning dose, is 100 milligram per day, but the maintenance dose after the attack dose is 50 milligram per day. And then sulfadiazine is 75 milligram per kilogram of the body weight, so it's according to body weight. And then the folinic acid dose is 15 milligrams. So that was all about this section, in which we discussed the rubella, syphilis, and toxoplasmosis, and the effect of these infections on the pregnancy. Thank you for watching sqadia.com.